This is Emily Lostbike, and today I will be going over the official journal of the International Society of Nephrology, their KDIGO Clinical Practice Guideline for Acute Kidney Injury. So first is the table of contents, which gives a rough overview of the document, including AKI definitions, the prevention and treatment of acute kidney injury, contrast-induced AKI, and then where dialysis can fit into the treatment of AKI. Then they also have the contents where the tables and figures are listed, which can be helpful for a quick reference of whichever topic you want a brief guideline of. We have the notice, work group membership, and then next I would like to discuss that the levels of recommendation are either level 1 or level 2, and then grades A through D. So the highest level is going to be level 1, grade A, which is the preferred as it has the best implications behind it, and then also has the highest quality of evidence supporting that recommendation, which means that we would be giving the highest quality of care to our patients. So those are important to consider when you're reviewing all recommendations throughout the document. Then we have abbreviations and acronyms, and then an abstract. So these next few pages go over just a summary of the recommendation statements, which is helpful so that you can see where a recommendation you're looking for fits throughout the document. So just a brief overview. My first clinical pearl comes from page 14 in the document, focused on figure 1 of the RIFLE criteria for AKI. So RIFLE stands for risk, injury, failure, loss, and end-stage kidney disease. Risk, injury, and failure are based off of increasing serum creatinine and decreasing urine output. These are really important lab values to be able to recognize in a patient's chart, as you'll be able to determine the severity of their renal function. Then with loss and end-stage kidney disease, that goes over the outcomes that can be occurring due to the risk, injury, and failure. So with loss, persistent acute renal failure can occur with complete loss of kidney function at greater than 4 weeks. And then end-stage kidney disease occurs at greater than 3 months. My second clinical pearl comes from page 47 of this document and discusses the use of diuretics in acute kidney injury. So many people would think that they should be used, as diuretics can sometimes be renal protective, can help prevent edema and treat acute kidney injury. However, as you can see in 3.4.1, a level 1B recommendation is not to use diuretics to prevent AKI. This is due to the fact that diuretics can reduce volume too much and can end up causing a pre-renal insult, which will cause or worsen AKI. So the only time that diuretics should be used to treat or prevent AKI is in the management of volume overload, so that we do not end up with an overcorrection of the volume, leading to more of an insult on the kidneys. Thank you so much for listening to my brief overview of the KDIGO clinical guidelines on acute kidney injury.